Hello everyone, this is Osama Naga. These are preview samples from different lectures from the most updated essential videos and lectures. All the updated lectures are in line with the Pediatric Board Study Guide, a last-minute review 3rd edition 2024. You are able to obtain this book or the print from Springer or from eBay in the links provided below the video. Pediatric Gastroenterology. This is a 2-year-old male with recent history of viral upper respiratory tract infection presenting with intermittent bouts of severe abdominal pain and lethargy with a palpable tubular mass in the upper abdomen on physical examination. The KOB showed soft tissue filling defect in the mid-transverse colon, and the ultrasound showed the classic target sign. What is the most likely diagnosis? This is a classic case of intussusception. Intussusception is very common in young children, may be preceded by upper respiratory viral infection or gastroenteritis like diarrhea. And the most important sign is severe abdominal pain or lethargy. Young infants may have just lethargy. And if you are lucky enough to know how to feel it, you may feel tubular mass in the right upper abdomen. And also an X-ray is showing the classic filling defect. And the most important sign, the ultrasound, is the most important diagnostic study for intussusception, the presence of target sign. Intussusception, what is intussusception? When a part of the intestine or the intestine is pulled antegrade into the adjacent part of the intestine, trapping the more proximal bowel in the distal segment. Initially, this will present with obstruction, bowel obstruction. And this is actually one of the most common causes of bowel obstruction in children. Then if it's not treated on time, this will cause ischemia. And ischemia after that will cause necrosis. And at this time you will have the blood in stool. And this is a late presentation. Then can cause bowel loss. The age, the most important age for occurrence of intussusception in infants. The age between 6 months and 36 months. This is the most common presentation. Common sites, junction of the ileum and colon. Lead points is important in older children. So if you have an older child like 5 or 6 years with recurrent intussusception, think about lead point like polyp or tumor or mecal diverticulum. Causes of intussusception, the cause in infants is typically unknown. Possibly because of enlarged mesenteric lymph node caused by viral infection will cause the intussusception. In older children, think about lead point like mecal diverticulum. Think about tumors like lymphoma polyp, hamartoma, or ganglioneuroma. Clinical presentation of intussusception, very important to know and keep in mind that lethargy and a change in mental status may be the only initial presentation, especially in infants and young children. The abdominal pain in intussusception may be vague all over the abdomen or periumbilical region, may be in the right lower quadrant. But in case if the pain in the right lower quadrant in intussusception will be intermittent, comes and goes. If it's appendicitis, will be continuous worsening pain. Lethargy is out of proportion. The child looks weak and lethargic, out of proportion of the abdominal pain, and diarrhea if he's having diarrhea. Vomiting may be bilious. The child will be pale and weak. The child may lie quietly between the peristaltic waves. Prolonged obstruction can cause abdominal distension and rectal bleeding. Rectal bleeding will look like a red currant jelly stool and is not commonly seen. I never seen it myself. But when it's seen, it suggests vascular compromise, meaning that the bowel is dying. The bowel is having necrosis. The ileocolic, which is a sausage-shaped mass, may be palpable on the right side or in the right upper quadrant of the abdomen. Diagnosis of intussusception. The best initial study is abdominal ultrasound. It may show the tubular mass. It will show the donut or target sign. Very classic. The ultrasound is very accurate in detecting intussusception. So it is your best option to start with. If it's positive, the next step is air contrast enema. It is diagnostic and therapeutic. The classic treatment of intussusception is air contrast enema. Same treatment if it's recurrent, unless the suggestion of lead point is very strong. Prognosis is very important to consult the parent about the possible recurrence. Recurrence rate is 10% after non-operative reduction. After air contrast enema, the recurrence rate is 10%, and this may recur within 72 hours. You have to let them know. More than one recurrence suggests a lead point. Very important to keep in mind. This is a 16-year-old boy with history of food allergies. Started having recurrent episodes of food impaction, difficulty with swallowing, abdominal pain, heartburn, vague chest pain, and diarrhea. Physical examination is normal. Labs are normal except for peripheral eosinophilia. What is the most likely cause? GERD, gastroesophageal reflux disease, esophageal adenocarcinoma, achalasia, eosinophilic esophagitis, peptic ulcer disease. The correct answer is eosinophilic esophagitis. This is an adolescent with history of food allergies. Start to have a new episodes or new onset food impaction, dysphagia, chest pain, and diarrhea, and labs showed peripheral eosinophilia. This is very classic for cases of eosinophilic esophagitis or EEE. Eosinophilic esophagitis or EEE is very important and high yield. Esophageal mucosa will be infiltrated with lots of eosinophils, more than 15%. Food allergy is the most common cause of EEE. Clinical presentation: vomiting, chest pain, epigastric pain, dysphagia. In adolescent, you will have food impaction and strictures. This should be suspected in adolescent with new onset of food impaction, high yield, very important to remember. And whatever medicine you will give for reflux will not work, ineffective anti-reflux therapy. Diagnosis of eosinophilic esophagitis: endoscopy is the mainstay for diagnosis and biopsy. You may see ring-like structures and small whitish papules representing eosinophilic abscesses. On CBC, you may see peripheral eosinophilia. Treatment of eosinophilic esophagitis or EEE: elimination diet with proven allergies or provide elemental diet. 75% respond to milk elimination. Almost 100% respond to amino acid formula, especially in infants and young children. For older children and adolescents, the mainstay of treatment is inhaled and systemic steroids and montelukast. If left untreated, this can cause esophageal strictures. How to differentiate EEE from pill-induced esophagitis? In pill-induced esophagitis or dry pill or drinking pills without water, this will cause deep singular ulceration at points of carina. General pediatrics. Failure to thrive. If the weight is affected more than the height, the most likely cause is nutritional. Failure to grow. If the height is affected more than the weight, is most likely hormonal. In this growth curve, you will see the percentile of the weight start to be affected between age 5 and 6 years of age, and here the height start to be affected afterward. So the most likely cause here: failure to thrive, nutritional or GI problem. In this growth curve, you will see the decline here, and the height is more affected than the weight, and the most likely cause here: height affected more than the weight is failure to grow, short stature, or endocrine problem. What is the average head circumference in a full-term infant? 25, 30, or 35, or 40, or 45 centimeters? The correct answer: 35 centimeters. Developmental milestones. At 4 months of age, there is no head lag. The infant is able to support the head 100% steady with no head lag. Able to lift the head and the chest, able to roll from front to back. When held standing, able to push with feet or able to bear weight on feet. Grasp an object and bring to mouth. Laugh out loudly. Imitates a social interaction. Palmar grasp is gone. Able to open the hand freely and let go. 4 months developmental red flags. If the infant is unable to hold the head steady, unable to bring things to the mouth, persistent fisting is abnormal, doesn't coo or make sound, doesn't smile at people. Early rolling between 1 and 2 months may indicate spasticity. Which of the following age an infant able to rake a small object without grasping? 4 months, 6 months, 8 months, 9 months, or 12 months? The correct answer is 6 months. 6 months is able to sit with support, turns from back to the front, and transfer object from one hand to the other, and stranger anxiety start at 6 months of age, familiar versus unfamiliar people. 6 months of age stops momentarily toward no, begins to make babbling, imitates sounds, turns directly to sound and voice, smiles, and vocalizes to mirror. 6 months developmental red flags if is unable to pass an object from one hand to another, doesn't try to reach an object, floppy like a rag doll, doesn't turn toward sounds, no smiling, no laughing, no expression. A 2-year-old boy brought to you by his mother worried about the number of his teeth and wondering how many teeth he should have at his age. 5 or 8 or 12 or 16 or 20 teeth. The correct answer, 16 teeth at 2 years of age. Timing of primary teeth eruption, 7 months 1 tooth, 11 months 4 teeth, 15 months 8 teeth, 19 months 12 teeth, 23 months 16 teeth, 27 months 20 teeth. So very simple, 7 months you have 1 tooth. So from all the following numbers just subtract 7. So 11 minus 7 equal 4, 15 minus 7 equal 8, 19 minus 7 equal 12, 23 minus 7 equal 16, 27 minus 7 equal 20. Sequence of primary teeth eruption. Mandibular central incisors, the lower, at 6 to 10 months. Maxillary, the upper, central incisor, at 8 to 12 months. Maxillary lateral incisor at 9 to 13 months. The first molars, 13 to 19 months. Canines, 16 months to 22 months. The second molars between 25 to 33 months. Neonatology. A newborn delivered via C-section, born cyanotic, poor respiratory effort, poor muscle tone, no grimacing, with heart rate less than 100. Continue to be the same after drying and stimulation after the first minute. What is the best next step? Chest compression, positive pressure ventilation, umbilical catheterization, intubation, or epinephrine administration? Correct answer, positive pressure ventilation. The reason why, poor respiratory effort and heart rate less than 100 after drying and stimulation. Initial management. Once the infant is born, dry the infant, clear the airway of secretions, provide warmth, place the infant under the radiant warmer, start neonatal resuscitation if indicated. Indications for resuscitation: apnea or poor respiratory effort, cyanosis, bradycardia, poor muscle tone. If the infant is apneic or gasping for air with a heart rate less than 100, start a positive pressure ventilation or PPV. Bag mask ventilation is initiated at a rate of 40 to 60 breaths per minute. After adequate ventilation for 30 seconds, if the heart rate remains less than 60 beats per minute, start chest compressions plus PPV using 100% oxygen. If positive pressure ventilation is ineffective or prolonged, or chest compressions are being performed, intubation or use of a laryngeal mask airway is needed. If the heart rate remains less than 60 beats per minute despite adequate ventilation and chest compressions, the next step is intravenous administration of epinephrine. Also, you can give epinephrine via endotracheal tube if vascular access is not available. When to stop resuscitation? Resuscitation efforts may be discontinued after 10 minutes of resuscitation if no signs of life, no heartbeat, no respiratory effort for greater than 10 minutes. Swelling of the scalp that is diffuse and crossing the suture lines. Here is well-defined soft tissue swelling that is firm initially then become fluctuant and is not crossing the suture lines. This is a classic case of caput succedaneum. It is common and usually resolves within 48 to 72 hours. Cephalohematoma is less common and resolves within 2 to 3 weeks to several months. Both cases reassurance. Genetic disorders. Autosomal aneuploidies. Autosomal aneuploidies. Aneuploidy means abnormal number, and here abnormal number of autosome. The first and most common example, trisomy 21 or Down syndrome. Second, trisomy 18 or Edwards syndrome. Third, trisomy 13 or Patau syndrome. We'll start with Down syndrome. Down syndrome is the most common example of autosomal aneuploidies. If you look at this karyotype from 1 to 22, these are all autosomes. If you look closely here at chromosome 21, you will see an additional chromosome. So this is autosomal aneuploidy in chromosome 21. You have 3 abnormal number instead of 2. So this is trisomy 21 or Down syndrome. These two are sex chromosomes XY. So this is a boy with Down syndrome or trisomy 21. Trisomy 21 non-disjunction is the most common type of trisomy 21, 94% of the cases. Robertsonian translocations is 3.3% of the cases. Mosaicism, which is a mix between normal cells and trisomy 21, is 2.4% of the cases. Parental risk of recurrence to have another child with trisomy 21 after birth of an affected child with Down syndrome is 1% plus the maternal age-related risk. Maternal age-related risk, for example, if you have a mother, her age 40 to 44 years of age, her risk is 1 in 100. If the mother age is over 45 years of age, her risk is 1 in 50. Risk of recurrence in cases of Robertsonian translocation, if the mother is 1421 translocation carrier, the risk is 10 to 15%. If the mother is 2021 translocation carrier, the risk of recurrence is 100%. Clinical manifestations of Down syndrome: intellectual disability, hypotonia. Hypotonia is very important because it may be the only obvious presentation after birth in cases of Down syndrome. Developmental delay, upslanting palpebral fissures. Speckled iris or brush-filled spots. Be familiar with both in cases of Down syndrome. Speckled iris or brush-filled spots. Brush-filled spots, they are whitish spots in a ring-like configuration at the surface of the iris. So again, speckled iris or brush-filled spots, Down syndrome. Single palmar creases can be normal in normal population but commonly associated with Down syndrome. Clinodactyly. Wide gap between great and second toes. Endocardial cushion defect. It is important to be familiar with conditions associated with Down syndrome. Hypothyroidism. Start by regular newborn screen. Then order TSH and free T4 at 6 months, 12 months, then yearly after. Celiac disease is commonly associated with Down syndrome. Screen for celiac disease if any symptoms, for example, recurrent abdominal pain, diarrhea. Screen with total IgA and tissue transglutaminase IgA antibodies. Pediatric dermatology. A 4-year-old boy with rash around the mouth for 2 weeks is not going away. The mother is been applying topical hydrocortisone and the rash keep getting worse. What is the most likely diagnosis of this rash around the mouth? The diagnosis is periorificial dermatitis or perioral dermatitis. The topical or inhaled steroids often contribute to development of this type of rash. You can see it in children that are using aero chamber with inhaled steroids for asthma. Also, if the parents they see rash around the mouth and they apply hydrocortisone or steroids, it is not recommended to apply hydrocortisone around the mouth. Will cause this type of rash. Perioral dermatitis or periorificial dermatitis is a common acneiform facial eruption in children. Clinical presentation, you will see red papules or papulopustules occurs around the mouth, the nose, and even the eyes. Management step number 1 is stop the use of topical corticosteroids and wash the face after each use of inhaled corticosteroids. You can apply topical antibiotics to help to clear this rash, such as metronidazole or clindamycin. For severe cases, you can use oral tetracycline or doxycycline or oral erythromycin. Improvement is slow, it often takes 6 to 8 weeks to clear. We have a patient presented with this rash, flesh-colored papules with central umbilication. This is another patient also presented with papules, flesh-colored papules with central umbilication. Here is so classic here, but this one from the itchiness becomes infected, as we also here also becomes infected from the scratch and the itchiness. Molluscum contagiosum is very common, caused by DNA pox virus called the molluscum contagiosum virus. Will give you flesh color, the classic flesh color, dome shaped, pearly, shiny in appearance with central depression. It may change from the scratch or the touch. Also very important to know that these lesions will take time to disappear. It may take few weeks to few months to disappear. Very important to teach the parents. So reassure them it's very benign, self-limited, and will go away. If cosmetically or psychologically distressing, then mechanical removal or cauterization. What is the most likely diagnosis of this case? Ear, nose, and throat. Hematoma of the external ear, commonly due to trauma. Hematoma in the external ear will decrease or prevent the blood supply to the ear cartilage. This will cause avascular necrosis and permanent damage to the underlying cartilage. Management of hematoma of the external ear, urgent aspiration of hematoma to prevent pinna deformity, for example, wrestler's ear or cauliflower ear. It is critical to apply pressure dressing after evacuation and a close follow-up to monitor for reaccumulation of blood. In this section, we'll learn how to read the audiogram. Hearing test is two components, air conduction and bone conduction. I will explain the air conduction. We use a headphone, and the headphone will produce sound in different degrees. The sound will travel through the external ear canal to the eardrum, through the ossicles, and finally to the cochlea and nerve. Any problem prevents the sound to be conducted from the external ear canal or from the middle ear to the cochlea and nerve. This will be called conductive hearing loss. For example, a child with excessive wax, impacted wax in the external ear canal. This can cause conductive hearing loss. Or a child with severe acute otitis media or otitis media with effusion with lots of pus behind the eardrum, preventing the vibration of the eardrum and preventing the sound to travel from the middle ear to the nerve. This will be called conductive hearing loss. Cases of excessive cerumen impaction in the external ear or otitis media with effusion, the ear conduction test will be abnormal, but the bone conduction test will be normal. The second component of the hearing test is bone conduction, and this is done by placing something similar to a headphone behind the ear on the mastoid process, and the sound will travel directly through the bone in the mastoid process to the cochlea and directly to the nerve, bypassing the external ear and bypassing the middle ear. Tympanometry. Tympanometry is a test of middle ear status, detects the compliance of tympanic membrane. It is quick. No cooperation is required from the child, commonly used to detect otitis media in pediatrics. Y-axis measures the compliance of the tympanic membrane. X-axis here measures the pressure on both sides of the tympanic membrane. 0 means that the pressure on both sides of tympanic membrane is equal, 0. On the positive side, the tympanic membrane here is very stiff with least compliance of tympanic membrane. Here, the tympanic membrane is very stiff with negative pressure and least compliance of tympanic membrane. In 0, this is the most compliance of tympanic membrane. This is normal type A with normal peak. Pediatric endocrinology. This is a 7-year-old boy with progressive headache, vomiting, bitemporal hemianopsia, short stature, weight gain, and fatigue. What is the most likely diagnosis? Cerebral gigantism, craniopharyngioma, migraine, or de Grouchy syndrome? The correct answer is craniopharyngioma. 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 Craniopharyngioma is the most common pituitary tumor. Clinical presentation, as we saw in the previous case, headache. Headache is the most common presenting symptom. Visual disturbance or bitemporal hemianopsia. What is bitemporal hemianopsia? Is impaired peripheral vision in the outer temporal halves of the visual field of each eye. Endocrine dysfunction, for example, hypothyroidism, diabetes insipidus, or deficiency of ADH or antidiuretic hormone, growth failure, and delayed puberty. Diagnosis: brain MRI with contrast. This is high yield. Suspect craniopharyngioma if you have sudden arrest of linear growth in later childhood or during adolescence. Management of craniopharyngioma: surgical removal. Thyroid diseases. Newborn screen of a 6-day-old boy showed abnormal thyroid stimulating hormone level of 230. The normal is less than 30, and physical examination is unremarkable. What is the best next step? Refer to endocrinologist, thyroid ultrasound, repeat the labs and follow up in 1 week, or start levothyroxine and order TSH and free T4 today. The correct answer is start levothyroxine and order TSH and free to 4 today to confirm the diagnosis. Starting the treatment in cases of congenital hypothyroidism early is critical. Referral to a pediatric endocrinologist is very important, but it may take time to see the patient. So starting the treatment early and confirming the diagnosis early is the most critical step to be done. Congenital hypothyroidism. Thyroid dysgenesis is the most common cause of congenital hypothyroidism. Clinical presentation: most infants are asymptomatic. Usually length and weight are normal at birth, but the head may look larger a little. Prolongation of physiologic jaundice is a very important sign of low thyroxine or hypothyroidism. Poor feeding, especially sluggishness. Choking spells during feeding, cold, mottled and dry skin, constipation that usually do not respond to treatment, large protruded tongue, apneic episodes or noisy breathing, umbilical hernia, large anterofontanelle, associated congenital anomalies, cardiac is the most common, hypotonia. Very important to know the early sign. Prolonged jaundice is the earliest sign of congenital hypothyroidism, along with somnolence, poor feeding, lack of interest, mottled skin. This is very classic early or classic symptoms in early presentation of congenital hypothyroidism. Laboratory: high level of TSH and low or undetectable level of free T4. No imaging study is required by most experts. Treatment of hypothyroidism should be started as early as possible. With levothyroxine, the dose is 10 to 15 microgram per kilo daily, and tablets only, no liquid. How to give tablets to an infant or newborn: crush it and mix it with water, breast milk, or formula. Very important not to mix it with soy milk formula. Then very important to repeat the labs. TSH and free T4 should be evaluated at 2 to 4 weeks after starting the medicine. Then every 1 to 2 months in the first 6 months. Then every 2 to 3 months between 6 months and 3 years. Then every 6 to 12 months thereafter. Also very important to repeat the lab 4 weeks after changing the dose. Pediatric pulmonology. Spirometry. We'll explain here the volume time curve. This is the volume time curve. This y-axis here is the air volume. If we have here 2, we have here 4, 5, and 6. And here the time inside, let's say this is the first second, third, and so on. So force vital capacity FVC and force expiratory volume in the first second FEV1. So how to do the FVC? You ask the patient to do full inspiration. Then you have to ask the patient to exhale as fast as possible, blow the air out of the lung as fast as possible, as quickly as possible, like that. So this patient successfully was able to exhale 80% of the air outside of the lung in the first second. This is well known as FEV1. What about here? All the air came out of the lung. After this process is called FVC, which is the volume of the air that can be forcibly blown out of the lung after full inspiration is FVC. FEV1, same like FVC, but just in the first second. If you have a patient with asthma, will not be able to do that because of high lung resistance, will be able to exhale maybe less than 70%. Then at the end will be able to exhale everything, so they will have normal or near normal FVC. So patient with asthma, they have normal FVC, normal. Patient with asthma, they have normal, and they have reduced FEV1. So this is the patient with asthma, this is normal, this is asthma. So forced expiratory volume in the first second, FEV1 is reduced in the patient with asthma. And same thing for the ratio will be reduced also in the patient with asthma. What about restrictive lung disease? If you ask the patient to exhale, they will not be able to exhale too much because they have a very low total lung capacity is reduced, and at the end also they will not be able to exhale everything, so they will have reduced FEVC and reduced FEV1. Again, to emphasize on the reading of volume time curve, the y-axis here is the air volume in liters. Here is 60 liters the max, and the x-axis is the time in second. Here is the first second. So you ask the patient to take a deep breath, then exhale as quickly as possible. So this patient successfully was able to breathe out most of the air out of the lung in the first second, say 80%. But the patient with asthma, you ask the patient to do the same. So this patient was not able to exhale most of the air out of the lung in the first second, say for example 60%, which is abnormal. So this patient with asthma having reduced FEV1, so FEV1 is reduced, and normal FVC. This is a case of asthma and this is normal. Again, to emphasize on how the curve or volume time curve looks in case of restrictive lung disease comparing to the normal able to exhale the air out of the lung in the first second, about 80%, and at the end exhaling everything and just what is left, only the residual volume. And here is called the forced vital capacity, which is normal in a normal person. But patient with a restrictive lung disease, they have this pattern, markedly reduced the FEV1 in the first second because of decreased total lung capacity, and at the end cannot exhale most of the air out of the lung and will have reduced FVC, while the patient with asthma will have always normal FVC or slightly below normal, but always very close to this area. Foreign body aspiration is relatively common and very important to have your high index of suspicion for foreign body aspiration, especially in a child with persistent cough. The nuts, especially peanuts, is 1/3 of cases of foreign body aspiration. Round globular foreign body are the most dangerous, like hot dog, grape, nuts, and candies. The common age is less than 3 years of age. Initial events after foreign body aspiration, violent paroxysm of coughing, choking, and gagging. You may have asymptomatic interval, and this will delay the diagnosis during this stage. The children with foreign body aspiration, they will present with recurrent wheezing or chronic cough, stridor, dyspnea, shortness of breath, cyanosis, retractions, diminished breath sounds. Sometimes they have normal breath sound on both sides. Important facts we have to know about foreign body aspiration. Positive history with choking or aspiration must never be ignored. We have to investigate. Negative history may be misleading because parents, maybe they were not around the child during the choking episode. Choking or coughing episode accompanied by wheezing are highly suggestive of foreign body in the airway. 58% they lodge in the right bronchus. The rest can be in the left side. Diagnosis of foreign body aspiration always based on high index of suspicion from the history and physical examination. But once you suspect a foreign body aspiration, first step, order chest and neck x-ray. But important to know that a chest x-ray is negative in 10 to 30% of cases, and lack of radiological findings never can be used to exclude an airway foreign body, as most of the foreign bodies are radiolucent, such as peanuts, almond, corn, and you will not see them on a chest x-ray. Chest x-ray result in case of foreign body aspiration, you may have normal finding, hyperinflation or air trapping, atelectasis or lobar collapse, mediastinal shift, infiltrate, pneumonia, or abscess. If you highly suspect a foreign body in older child, you can order an expiratory view, or bilateral decubitus in young children. Bilateral decubitus, this is very helpful. This is a bilateral decubitus chest x-ray. Order that if you highly suspect a foreign body aspiration, especially if it's radiolucent. So here this is right dependent x-ray and showing right volume loss on the dependent side. If you look on when the child lay down on the left side, there is no volume loss indicating air trapping in this area. So this child is having left-sided foreign body. Management of foreign body aspiration, the treatment of choice is prompt removal with rigid bronchoscopy. Bronchoscopy can be deferred or delayed until proper hydration, emptying of the stomach. Complications: if the foreign body left without removal, this can cause bronchiectasis, hemoptysis, and lung abscess. Pediatric cardiology. Chest pain in children and adolescents. This is a 15-year-old adolescent boy is brought to you for evaluation of a chest pain. He had a chest pain 2 days ago during soccer game and had to leave the game. He describes the pain as dull and points to the middle of his chest. It was worse when he was running. This is very important. The pain resolved with rest and fluids. He denied rapid heartbeat sensation. No family history of sudden death or death under the age of 30 years. He denied using any illicit drugs. Physical examination is normal. EKG showed ST segment elevation from V1 through V6 with ST segment depression in the inferior leads. What is the most likely diagnosis? Musculoskeletal pain, precordial catch, anomalous coronary artery, or exercise-induced asthma? The correct answer here is anomalous coronary artery. The key point here that this adolescent has the pain when he was running during exertion. This is a red flag for cardiac chest pain. Non-cardiac chest pain is the most common cause of chest pain in pediatrics. Taking a detailed history and physical examination is the key, and this can establish the diagnosis of pain in most cases. Cardiac chest pain is rare. However, we have to explore and ask the proper questions to rule out any cardiac source of the chest pain. Precordial catch syndrome is a very common benign musculoskeletal chest pain in older children and young adults, presented with severe and sudden chest pain over the heart, over the left precordium. The child or adolescent will describe the pain as knife-like sharp pain. And during the episode, the child will look like he cannot catch or she cannot catch her breath. Especially deep breath will make the pain worse. The child has no limitation with exercise, no problem with physical activities. The pain classically lasts for 30 seconds to 1 minute. Physical examination is typically normal, the cause is unknown, and the management is reassurance. No investigations are required whatsoever. Red flags for cardiac chest pain: ask for pain with exertion, pain with exercise, pain during swimming, syncope or collapse during exercise or while swimming, fatigue, shortness of breath with exertion or activities, pain preceded by tachycardia like cases of supraventricular tachycardia, family history of heritable conditions such as hypertrophic cardiomyopathy. Cardiac arrhythmias or electrocardiography can be abbreviated as ECG or AKG. This is a 12 leads ECG 10 seconds recording. We have large squares and small squares. Each small square equal 1 millimeter by 1 millimeter in size. Each large square has 5 small squares by 5 small squares, or 5 millimeters by 5 millimeters. Very important to look at the calibration. Standard calibration is 2 large squares for the amplitude. 2 large squares for the amplitude, or 10 millimeters. The standard speed is 25 millimeters per second. In this case, each small square equal 0.04 seconds or 40 milliseconds, and each large square equal 0.2 seconds or 200 milliseconds. In this case, 5 large squares will be equal 1 second. If 1 second equal 5 large squares, this means 60 seconds equal 300 large squares, or 1 minute equal 300 large squares. If we take one cardiac cycle from here and we look at it, we have wave, we have segment, we have complex, and intervals. So wave means deflection. If the deflection is above the baseline is positive, if it's below the baseline is negative. Then we have segment, which is a portion of the baseline, and interval means a wave plus segment, and complex means multiple waves without segments. P wave represents atrial depolarization. PR interval represents atrioventricular conduction, and the QRS complex represents ventricular depolarization. ST segment and T wave represent ventricular repolarization. The QT interval from the beginning of the Q to the end of the T means the duration of ventricular depolarization and ventricular repolarization. When we look at the ECG, we have 12 leads ECG, and we look at the rhythm leads in the bottom. The rhythm leads in the bottom to look at the rhythm and rate. Then you have here the 12 leads. You have lead 1, 2, 3, AVR, AVL, AVF, V1 to V6. Lead 1, AVL, and V5 and 6, they are well known as lateral leads, and they look at the electrical activity of the lateral wall of the left ventricle. Then you have 2, 3, and EVF, well known as inferior leads. Inferior leads, they look at the electrical activity of the inferior surface of the heart. Then you have septal leads V1 and V2, and V3 and V4, well known as anterior leads, and they look at the electrical activity of the anterior wall of the right and left ventricle. V1 and V2, they are a great window for the right ventricles. V5 and V6, they are great windows for the left ventricle. Then when you look at the ECG, you start to analyze the waves, and we need to be familiar with the variation of waves in different leads, and also variation of waves according to the age. So if we start here, PQRST, 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 you see here the P wave is positive in lead 1 but is negative in AVR. This is normal. So if you look at here, also the T wave is positive in lead 1 but is negative in AVR and V1. This is also normal. But T wave can be positive normally in newborn less than 7 days or less than 1 week of age. Afterward, if it stays positive, this is suggestive of right ventricular enlargement, just suggestive, but can be normal in older children, like older than 6 to 7 years of age. Then we need to look at the QRS ratio and variation according to the age. This ECG is for 8 years old. If this is a newborn, you will see the R wave here in V1 is larger than that, and the S is smaller than that. As the infant and children, they grow, the R wave keep declining, keep getting smaller in V1, and the S keep getting deeper, and the opposite occurs in V6. So this is also variation. Very important also to know that the QRS ratio in V1 is different than the QRS ratio in V2 and V3. So this is very important to consider before start reading an ECG. Very important to have a systematic approach when you are reading electrocardiogram in order not to miss any important information. Step 1, you look at the rhythm, rate, and the axis. Step 2, to look at the P wave, PR interval. Step 3, QRS complex. Then step 4, you look at the QT interval, ST segment, and finally T wave. This is a 6-year-old presented with difficulty breathing, then collapsed. What is the most likely diagnosis? If you look at the EKG here, you have tachycardia. You see the QRS complex is wide and bizarre, QRS complex and tachycardia. What is the most likely diagnosis? Atrial flutter, atrial fibrillation, ventricular tachycardia, ventricular fibrillation. The correct answer is ventricular tachycardia. Ventricular tachycardia, definition of ventricular tachycardia in children is defined as tachycardia of at least 3 successive ventricular beats. A ventricular, when we say ventricular, means that the QRS will be wide and bizarre. Wide complex, not narrow complex. If it's narrow complex, it will be supraventricular, not ventricular. Ventricular when the complex is wide, and we'll see it in the example. Causative factors include drugs, caffeine, decongestant, so be careful about prescribing decongestant, especially to very young children. Be careful with the dose. Electrolyte imbalance, underlying cardiac disease, prior cardiac surgery, and cardiomyopathy. We'll start a new section, heart murmurs. In this slide, we'll classify the murmur according to the source. If the source is from the aortic valve or pulmonary valve, if the lesion is stenosis or the pathology is stenosis, will give you systolic murmur. If it's regurgitation, will give you diastolic murmur. If the source of the murmur is mitral valve or tricuspid valve, if it's stenosis, will give you diastolic murmur. If it's regurgitation, will give you systolic murmur. Step 1 in listening to the heart, auscultate while the patient is supine. Step 2, auscultate while the patient is sitting. Finally, auscultate the back. When you check for murmur, check the loudness of the murmur. We grade it from grade 1 to grade 6. Grade 6 is the highest, grade 1 is the lowest. Timing of the murmur, systolic or diastolic. Location of the murmur will help you to identify the source of the murmur. Radiation of the murmur and pitch of the murmur. Innocent murmurs are typically quiet, grade 1 or 2. Systolic, located over left sternal border, possibly radiate to left or right sternal border. Low pitched, vibratory or musical, decrease in intensity from supine to sitting position. This is a child coming for routine physical exam. In your examination, you find or you heard ejection systolic murmur with a vibratory character, best heard on the lower sternal border towards the apex. What is the most likely diagnosis? Still's murmur, venous hum, VSD, or ASD? The correct answer is Still's murmur. Again, to emphasize on Still's murmur or innocent murmur, because it's extremely common in pediatrics. And this type of murmur require only reassurance. No echo, cardiogram, no referral to a cardiologist because of this murmur. It's very benign. It is non-radiating, early systolic ejection murmur, low intensity between 1 to 2/6, short duration, located at the left lower sternal border, vibratory or musical quality. I will give you a few seconds to listen to this murmur. Another common innocent murmur in newborn, peripheral pulmonary artery stenosis of the newborn. The murmur is related to the take-off angle of the branch of pulmonary arteries in the newborn. Characteristics of this murmur: systolic ejection murmur of low intensity, best heard at the left upper sternal border and radiates bilaterally to the axilla and the back. Remember, the innocent murmur or Still's murmur doesn't radiate, but this murmur radiates to the axilla and the back. Louder actually in the axilla or the back than the anterior chest. A split second heart sound of normal intensity. This murmur is benign and disappears by 3 to 6 months. This is a 6-year-old with systolic diastolic murmur, low-pitched sound, best heard in the infraclavicular region, disappears when supine and with gentle pressure on the jugular vein. What is the most likely diagnosis? Still's murmur, venous hum, VSD, ASD. The correct answer is venous hum. Pediatric orthopedic. Hip disorders. Developmental dysplasia of the hip, or DDH. Very important to note by heart. You cannot miss the diagnosis of DDH. DDH ranges from complete dislocation of the hip joint, means that the femoral head is outside the acetabulum, to dysplasia of the acetabulum, which is a shallow acetabulum. Risk factors of DDH: breech positioning in utero or breech presentation, especially in the third trimester, female sex, being firstborn, positive family history. Very important to ask about family history of DDH. Other conditions related to prenatal positioning or breech presentation or narrowed uterus, metatarsus adductus and torticollis are commonly associated with DDH. Another important risk factor is improper swaddling. Improper swaddling can cause DDH. Diagnosis of DDH in neonatal period: very important to do screening from birth and in each subsequent well visit using Barlow and Ortolani, either with or without risk factors. So it is mandatory for all pediatricians to do Barlow and Ortolani for all newborn in the hospital, after discharge, and in each subsequent well visit. If you suspect a case of DDH, order hip ultrasound if the age less than 4 months. From 4 to 6 months and ideally from 6 months, plain radiographs will make the diagnosis as well. Will show the dislocation and dysplasia. The best screening method for DDH is Barlow and Ortolani maneuvers during neonatal period up to 2 to 3 months. After 3 months, it will be difficult to do that. So you hold the thigh in this position, the thumb is inside and the 4 fingers outside over the greater trochanter. You hold the thigh gently, don't apply too much pressure, and you hold the thigh into the position of adduction, and you apply gentle anterior pressure. Barlow will try to dislocate the head of the femur out from the socket of the hip joint. If it's positive, you will feel a clunk and you will feel the head of the femur coming out. And Ortolani afterward, you do Ortolani after, and you hold the thigh in abduction position, And in this case, you are trying to relocate the head of the femur into the socket of the hip joint. If you feel the clunk and you feel the head of the femur is returning back and is easy, this is positive. This is a case of developmental dysplasia of the hip. If Barlow's and Ortolani maneuvers are positive, refer to a pediatric orthopedics. You do not need to order an ultrasound. Positive exam is enough to refer the infant. This is AP pelvis radiograph for a 14-month-old girl with developmental dysplasia of the left hip. If we look at the ossific center on the left side is much smaller than the ossific center on the right side. This is the left, this is the right. And if we look at the Hilgen-Reiner line is drawn in the inferior portion of the iliac bone on both sides, and Perkin lines is perpendicular crossing the acetabular roof. And here you will see the location is different than here. So on the left side, the ossific center is located in the upper lateral quadrant, while the ossific center on the right side is located in the lower medial quadrant. This is a case of DDH on the left side. Diagnosis of DDH or clinical presentation of DDH. Positive Barlow and Ortolani in the first 3 months of life. In older children, when they start to walk, they will present with limping if it's unilateral or waddling gait if it's bilateral. Limb length discrepancy is one of the manifestations, and the dislocated side will be the shorter side with limited abduction of the affected side. Limb length discrepancy or unequal limbs can be detected by Galeazzi sign. Very important to be able to perform this exam, Galeazzi sign, by flexing both hips and knees on a flat table. And you look at or you compare the knee height in both legs on the right side or on the left side. If you look at this positive case, this is normal. So the right side is normal, and this child is having shorter, the knee is below the other one than the right side. So this is a case of DDH on the left side. DDH screening by ultrasound at 4 to 6 weeks. If you have a breech position in the 3rd trimester, so this is a risk factor, but the exam is normal. In this case, order a pelvis ultrasound at 4 weeks of age. Ordering earlier than that, like after birth, will give you false positive result. Is a risk to have false positive result. So it is important to wait 4 weeks, then you order the ultrasound. Family history of DDH, also order, and your exam is still negative, order ultrasound at 4 weeks. History of abnormal hip physical examination in the neonatal period. History of improper swaddling, you can order at 4 weeks. Also, your exam is still negative. Suspicious or inconclusive physical examination. You are not sure about the physical examination, you can order also ultrasound at 4 weeks. Treatment of DDH. Orthopedic referral for Pavlik harness for infants less than 6 months. Pavlik harness will be worn for 24 hours a day, and the parents are able to change the diaper while wearing the harness. For how long to wear it for? For 6 to 12 weeks. Closed reduction and casting for children 6 to 18 months with DDH. Open reduction for children more than 18 months with DDH. Internal tibial torsion. Internal tibial torsion is another cause of intuing, and this is the most common cause of intuing in children around age of 2 to 3 years. How to make the diagnosis of internal tibial torsion? Very important to let the child lay down on the table in prone position, then flex the knee as the examiner is doing. Then you have to look at the direction of the foot. If the direction of the foot pointing externally like that, this is normal. If it's pointing inward like that, this is internal tibial torsion. Very easy. This picture is a lifesaver. Keep it in your clinic, will help you a lot to make the diagnosis of internal tibial torsion, as this is usually resolved by itself. And very important to know also, internal tibial torsion in infants or neonates is normal as a result of the intrauterine position. And as they grow, the foot will turn outward and the intuing will disappear as this normal child. After you make the diagnosis of internal tibial torsion, no treatment is required. Reassure the parents. The condition usually resolves spontaneously over the first few years of life. No orthotics, just reassurance. Adolescent medicine. Substance and drug abuse. Tobacco use by adolescents can become a serious drug addiction. There is an increase in e-cigarette use in adolescents. Smoking is dangerous and can be a gateway to serious drug addiction. E-cigarette or vaping product associated lung injury, EVALI. EVALI is a lung injury caused by homemade solutions containing vitamin E acetate with or without tetrahydrocannabinol THC. EVALI is usually mistaken for pneumonia. Consider EVALI in patients with pneumonia who are not responding to oral antibiotic treatment with history of vaping or using e-cigarettes. Clinical presentation: persistent, difficult to treat cough, fever, dyspnea, GI symptoms. Investigations: white count will be elevated leukocytosis, elevated liver enzymes, elevated ESR and CRP. Chest X-ray may reveal diffuse, bilateral, ground glass infiltrates, basilar predominance, and subpleural sparing. Management: most cases of EVALI responded to systemic steroids, not to antibiotics. Assess adolescents' willingness to quit smoking at each clinical encounter. Motivational interviewing is the best. If at the stage of readiness for behavior change, help the adolescent to move forward. School and community support program is important. E-cigarettes counseling is important. Promote family strategies to avoid exposure to e-cigarettes. Pediatric neurology. Neurological examination. Babinsk reflex, very simple to do. Firmly scratch the sole of the foot from the heel on the lateral aspect or on the lateral side, going up towards the little toe, then finally towards the big toe. And the result, you will see normal reflex, the toes will be down, flexion. The toes will go down, flexion. This is normal. Abnormal, positive Babinsk reflex, if you see fanning or toes up or extensor plantar response, this is abnormal, but this can be seen normally in children less than 3 years of age. This 14-year-old male was found in the bathroom on the floor, shaking all upper and lower extremities non-stop. He was stiff and drooling. He never been diagnosed with seizures before, but his parents noticed him having some jerks in the morning. And sometimes the toothbrush fell from his hands, and he always looked clumsy in the morning. His physical examination is unremarkable, and his EEG is positive for spike and polyspike wave. What is the most likely diagnosis? Juvenile myoclonic epilepsy, absence seizure, benign epilepsy with centrotemporal spikes, drug overdose, Rasmussen encephalitis. A 7-month-old boy suffers from recurrent complex febrile seizures, which only occur when he has a fever. The last episode of febrile seizures lasted for 30 minutes. He babbles, he can sit alone, smiles, and transfers objects between hands. His physical examination is unremarkable except for 2 large white macules on the trunk, and his family history is negative for seizures or any other significant medical conditions. What is the best diagnostic test? EEG, brain MRI, renal Doppler ultrasound, abdominal CT scan, complete metabolic panel. The correct answer is brain MRI, looking for tumors because of risk of tuberous sclerosis. He has recurrent complex febrile seizures or seizure or epilepsy in general, plus 2 large white ash leaf spots, which is the white macules on the trunk. So very important to rule out tuberous sclerosis in this case. Tuberous sclerosis. Tuberous sclerosis is inherited as autosomal dominant because of mutation in chromosome 9 or chromosome 16. Incidence is 1 in 6,000 live births. 50% may be spontaneous mutations without positive family history, as in the previous case. Major features of tuberous sclerosis: ash leaf spots. Ash leaf spots are white macules or skin hypopigmentation. Very important for any child with autism or recurrent seizures or developmental delay to examine the skin for hypopigmentation or ash leaf spots. Very important not to miss it. Chagrin patch. Chagrin patch is a connective tissue hamartoma can be found in the lower back. It has a texture of leather or leathery textures. Preangual fibroma, facial angiofibroma, as you see here, this is facial angiofibroma, can be mistaken for acne. So, but this one clusters around the nose. Cardiac rhabdomyoma, you can have the rhabdomyoma in the heart because of tuberous sclerosis. Renal and pulmonary angiomyolipoma, so affect the kidney and the lung. Cortical tumors or subependymal giant cell astrocytoma, and this can cause obstructive hydrocephalus. Clinical manifestation or symptoms of tuberous sclerosis: seizures. This is the most common presenting symptoms. So any child having seizures, you have to examine the skin for ash leaf spots or skin hypopigmentation. Infantile spasm, learning disability, intellectual disability, commonly associated with autism, ADHD, or obsessive compulsive disorder. Management of tuberous sclerosis: seizure control, echocardiogram for the heart, for cardiac rhabdomyoma, blood pressure check because the tuberous sclerosis affects the kidney, renal ultrasound, neuroimaging or head CT or MRI. The correct answer is epidural hemorrhage. Epidural hemorrhage appeared on CT scan as convex or lens-shaped hyperdensity. Epidural hemorrhage is bleeding between dura and skull. Bleeding between dura and skull. The affected vessels: arterial bleeding, middle meningeal artery, this is the most common, associated with temporal skull fracture. In children can also occur from venous bleeding and is not always associated with skull fracture. On CT scan will appear as convex lens-shaped hyperdensity. Research and statistics. Start a new section, study designs. Randomized controlled trials. This is the best study design. This is the gold standard to evaluate risks and benefits of a new treatment. Randomized means no selection bias, means different ages, different genders. Controlled. That's why this word came from. We have a control group. Control group is the one who will be receiving the placebo. And the treatment group is the one who will be receiving the new treatment or the active drug. And we have to have both groups, the treatment group and control group, very similar or very close to each other in terms of ages, genders, education, disease history. They have to be close as possible or no major differences. Again, to emphasize, in randomized controlled trials, the best to be double blind. It means neither the subjects nor the researchers know which one is using the active drug and which one is using the placebo. Randomized controlled trials has high internal validity, means high confidence in the results, that the results are valid and not influenced or changed by other factors. Also reduced risk of confounding variables, and this is very important. Let's move to a new section, screening and diagnostic testing. Now, sensitivity and specificity. Sensitivity measures who truly have the disease, true positive. Specificity measures who truly doesn't have the disease, true negative. The first step to learn how to calculate sensitivity, specificity, positive and negative predictive values, to learn how to draw the four-square model. The top part is positive, the bottom part is negative. So negative, negative, positive, positive. So positive and positive, this is true positive, and the opposite here will be true negative. Of course, here the top part positive, this will be false positive, and the bottom is negative, so will be here false negative. Again, here is true positive, here is true negative, and the top part here will be false positive, and here will be false negative. What is false positive? False positive occurs when the test reports a positive results for a person who is disease-free. False negative. False negative occurs when the test reports a negative result for a person who actually has the disease. How to calculate sensitivity? Very easy. You will take this portion of the 4 square and you drop an arrow like that. Will be true positive because you are calculating sensitivity, true positive divided by true positive plus false negative. True positive divided by true positive plus false negative. So do you calculate a specificity? You will take this portion of the 4 square, and this is the true negative because you are calculating a specificity. You will take the true negative and you drop an arrow divided by true negative plus false positive.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple-choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams!